Hey, good day and good evening, everyone. We have the next week behind us and the next IVF webinars ahead of us. So before we will start, please let me know if you can all hear me and if everything is working fine. I hope. Yes, and thank you for the feedback already. I'm Sophie and I'm your host today. Welcome to IVF webinars by Egg Donation Friends. No matter if you are with us for the first time or you join us maybe week by week, it's a huge pleasure that you decided to spend this evening with us. And we are here to help you along your IVF journey, and we do IVF webinars every week. Once a week or twice a week, like this time, and we will meet as well on Thursday, but about it a little bit later. Anyway, all IVF webinars are recorded and the rewatch is available on our website the next day after the live event, and you can find it all at eggdonationfriends.com/IVF-webinars. IVF webinars are brought to you with help of our partners, and our partners are National Fertility Society, fertility clinics abroad, and Donor Conception Network. And today, we are here to explain once and for all IVF success rates. Dr. Hana Visnova accepted this challenge, and you may know her already from her previous webinar, which she did earlier this year in April on the topic of fresh or frozen oocytes for your IVF with donor eggs. So it's also worth of your attention as well. Dr. Hana Visnova is medical director at IVF Cube Prague. She's ASHRA member and in 2019 awarded by American Society for Reproductive Medicine for a research study associated with IVF therapy, and she's devoted to the medicine and working in harmony to her motto to treat every patient such as the best friend. So we will start with the presentation by Dr. Hana, and the presentation will take around 20-25 minutes. And then we will continue with the questions. So don't hesitate and type those questions in the chat section so they will be ready for the right moment for me. And we will continue with the Q&A session after the presentation. Okay, Dr. Hana, are you ready? If you are, we can start. So fingers crossed and let's do this.
Hi, good evening, everyone. My name is Hana Visnova. Sophie, thanks for your introduction. I would like to explain you the success rates, how to understand the options of success during the IVF treatment, what are the typical statistical methods used, and how to compare different results which you may read on websites of different clinics or in the scientific literature. So usually everyone is concerned to find out what is the pregnancy rate, what are your chances to get pregnant. But we need to specify what is the pregnancy rate meaning. You as patients who hopefully do follow today's discussion, you are probably interested if you will succeed if you commence the treatment, as that means if you decide to commence the IVF treatment, you have a long journey in front of you. You need to purchase expensive medication. You need to start with daily administration of injections, which might be very uncomfortable. You need to probably to travel to the clinic. You spend a lot of time because of ultrasound investigations, blood sampling. So the pregnancy rate might be considered per treatment commence. That means to include all girls who decided to start any kind of stimulation. But you can also speak about pregnancy rates related to egg retrieval. Unfortunately, not every patient, every female who decided to start the IVF treatment will reach the day of egg retrieval. Depends on the age group of the patient, depends on her hormonal situation. Maybe 10 to 30% of patients who started stimulation with daily injections do not proceed so far to have the option to be scheduled for egg retrieval. But we must understand that there is a huge gap between number of treatments started compared to number of treatments or number of females who achieve their goal of egg retrieval. Another option how to understand the pregnancy rate is to calculate number of pregnant women who underwent embryo transfer. And again, there is a gap between those who went through egg retrieval and those who finally got a nice embryo suitable for embryo transfer. So once you read any scientific literature or once you speak to any medical professional regarding pregnancy rate, ask them what are your chances of success if you decide to start the treatment, if you decide to spend the time and money and your emotions prior to starting any stimulation. Later, when we speak about pregnancy rate, we also need to understand how many embryos are used for embryo transfer. You have number of countries and clinics who perform just elective single embryo transfer. That elective single embryo transfer means that we pick up the very best embryo from a larger group of suitable embryos. Then we can reach higher pregnancy rates compared to single embryo transfer, which means just a single embryo transfer because we don't have any surplus embryos for a better selection. And of course, clinics and countries who perform double embryo transfer or even 3 embryos or even more embryos are used for transfer, their pregnancy rates, of course, are higher as of those who perform single embryo transfers. But on the other hand, you should always consider your safety if you decide to start IVF treatment. The best pregnancy for any female is a singleton pregnancy. Singleton pregnancy gives the best chance of uncomplicated course of pregnancy, uncomplicated delivery, and the best health condition of the child. So once you decide to undergo a treatment in a clinic where are 3 or even more embryos typically selected for transfer, then you must accept higher risk of complications. So please be careful when reading pregnancy rates. How many embryos in average are transferred to the womb in one treatment cycle? One of most important prognostic factors is the age of the female. So usually the scientific literature reports pregnancy rates in different age cohorts separately. So once you want to know your chance of success, please look which age cohort you belong to and check for data according to your age cohort. You cannot confirm the success rate of the pregnancy rate for the girl who is 25 years old. You can't confirm it to the age group of females age 35 or even age 45. Unfortunately, there is a decline of success rate according to the age of the female anyway. And of course, once understanding the pregnancy rate, we need to notice if the embryo was genetically tested prior to administration or if there was not any genetic testing done. Because genetically tested embryos give higher pregnancy chances compared to not tested embryos. Next important thing is to understand what is the implantation rate. Pregnancy rate means how many females get pregnant, but implantation rate means how many embryos implant. Imagine the situation that you have, let's say, 10 women with comparable quality of embryos, and they all choose 3 embryos for embryo transfer, and you achieve, let's say, 10 pregnancies. Then you have the implantation rate 30 times lesser compared to 10 girls who have chosen just a single embryo transfer, because simply we calculate how many embryos implanted, not how many females got pregnant. If you calculate fresh embryo transfers and you consider also the option of using frozen embryo transfer in the near future, we speak about cumulative pregnancy rate. Usually we don't obtain just a single or 2 embryos of good quality. We may have 4 or 5 embryos of comparable quality. So if we come to situation that all available embryos have been chosen for transfer, we can almost double the chance of pregnancy rate per treatment cycle, meaning per treatment what you have purchased and per treatment when you have underwent egg collection. Take-home baby rate or live birth rate is really the number of children born after the successful treatment. And again, there might be a difficult understanding of single embryo transfers and double embryo transfer, as the live birth rate also includes the twin rates. So we should calculate it as 1 live birth rate, not like 2 live birth rates, otherwise we will come over 100%. So this is like a statistical, mathematical exam, which is sometimes difficult to explain to patients, but once we have live birth rate, regardless if this was a singleton or double embryo transfer, we should calculate it as one birth, not 2 children born. But we can again speak about cumulative live birth rate. So that means if we have 3 embryo transfers and we got 3 times a singleton pregnancy, we have better results as if treatments using 3 embryos in one attempt, resulting in a singleton or twin pregnancy. Another important medical term is what is actually the pregnancy. We can distinguish between biochemical pregnancy. Biochemical pregnancy means a short time of positive pregnancy test. Usually just the urine home kit is positive. Sometimes blood levels of the beta HCG reach positive levels, but the pregnancy does not proceed, and usually a bleeding occurs in few days after the testing. Such pregnancies should not be included in any statistical calculations of success rate. We should calculate only those pregnancies which are confirmed with the ultrasound. Viable pregnancy is confirmed. So viable clinical pregnancy means that we have seen on an ultrasound scan a gestational sac with a healthy, viable embryo and a heartbeat. Ongoing pregnancy is next step. Ongoing pregnancy means that the pregnancy has developed further and the first trimester was completed. So that means that most fetal abnormalities were eliminated and the pregnancy has excellent prognosis to continue further and finally to result in a healthy delivery. And the live birth rate, as explained earlier, that means really how many children were born. And again, those pregnancy rates should be, in the best scenario, calculated per initiated treatment, not per embryo transfer or per egg collection. Here, for example, I can show you what have been our pregnancy rate during the year 2018. You can see the comparison of numbers of embryos used for embryo transfer. In our clinic, the preferred way of treatment is a elective single embryo transfer. But of course, some patients, based on their personal medical history, they prefer a double embryo transfer. So we transfer an average of 1.4 embryos. And for egg donation treatment, the average number is 1.39 embryos per treatment cycle. In both group of our patients, the average age is slightly above 40. Using OUNEC treatment, we have achieved 46.7% pregnancy rate, clinical pregnancy rates. And for egg donation, we have achieved 64.4% of pregnancies using 1.4 embryos for transfer in the age group of approximately 41 years of age. In the lower part of the slide, you can see the distribution over age cohorts, and you can see how dramatic is the decline of success rate if we speak about OUNEX, especially at the treatment groups of advanced maternal age above 40. On the other hand, egg donation treatments gives very good pregnancy rates even at the age above 40. If we perform PGT genetic testing as screening for aneuploidies, we can eliminate genetically abnormal embryos from embryo transfer. So we have more precise selection of embryos for transfer, and this helps us to improve the success rate per single embryo transfer to 65%. So this is a method of choice because it can save you time and not using those embryos which will never implant because they are not genetically normal. So let's say if you have 3 or 4 embryos of similar morphological quality, that means they look under microscope very well. We don't expect that each embryo will implant. But we can, with the help of PGT testing, we can choose the best embryo so we don't spend time and you as a patient don't lose time with using those embryos which will never get implanted, so you can shorten your time to achieve a pregnancy. Speaking about success rates, you can also look to the situation how many eggs finally implant. And as you see the picture on the slide, there is a real biological waste of eggs. Only approximately 30% of available eggs develop further and reach the stage of blastocyst, which is an embryo suitable for embryo transfer. But from all eggs what we retrieve from patients, only 6% of them finally implant to the uterine cavity, and only 5.8% of eggs really implant and result in a clinical pregnancy. Similar data you can find in the world literature, and so usually most scientists really report the chances for an egg to implant and result into pregnancy to vary between 5 to 7%. As we have published before, there is also a difference of how many oocytes implant in the fresh stage and how many oocytes, how many eggs implant if they are frozen from certain reasons. This might be freezing of oocytes as a social freezing or freezing of oocytes in egg donation, egg banking program, or freezing oocyte because of an emergency situation where are no sperms available for the fertilization. So as you can see, when we need to freeze oocytes, then we have just 3.7% of eggs implanted, resulting in a healthy delivery. So there is again a gap because of the freezing method. Other way how to understand the success rate is to think about it, how many eggs you need to get retrieved to result in a baby. How many eggs you need actually? What should be the outcome of your stimulation, or what should be your outcome, expected number of eggs in egg donation programs? How many eggs you need to obtain from the donor to have good chance to achieve a pregnancy and delivery. So if you have fresh eggs available for the embryo transfer and you belong to good prognostic group of patients, or this is a egg donation treatment, then you probably need 7.6 eggs to have a baby. But if you use frozen eggs, especially egg donation programs, social freezing, then you need probably 14 eggs to have good chance to get a pregnancy. Those data are only for young good prognosis patients, or let's say young good prognostic eggs. For females above 35 years of age, is known that you need probably 30 eggs if you do a social freezing to have 90% chance of a pregnancy. And there are also difficulties in understanding. Once you want to understand the pregnancy rate, you should also understand that some pregnancies, unfortunately, end with miscarriage. Miscarriages could be early miscarriages, but we also, as in any medical field, we see some complications. Those complications may result to pregnancy terminations, but usually those pregnancy terminations do not correspond to the quality of the IVF laboratory or IVF clinic, because most of them are related to maternal health conditions or medical history of the mother or advanced maternal age, especially preeclampsia is a disorder who is related to advanced maternal age. And also some fetal abnormalities like heart failures, kidney abnormalities, intestine abnormalities develop during the later stages of development of the embryos and could not be eliminated completely. As explained earlier, we should always distinguish if we do an elective embryo transfer. That means that we choose the really best embryo from a larger group of embryos, or if we speak about pregnancy rate per embryo transfer without the option to select the best embryo for. And at the final moment of my presentation, I would like to highlight that we need a very good cooperation with our patients, because we want to know our data. We want to know how many deliveries we got. We want and we need to know if children born after the treatment are healthy children. We need also patients to report abortions, because only then we can be exact and we can have good statistical data available for next clients to be sure that we do not underestimate their chances to get pregnant. You would be surprised how difficult it is to obtain sometimes the delivery details. Sometimes it takes 2 years of contacting until we recognize if the pregnancy was successful and that there was a healthy child born to include the results to our pregnancy rates. Because only if we have completed data, we can give exact calculations and help next clients, and do not give them false hopes, or we don't then underestimate the chances of successful treatment. So I hope I have explained the difficult statistical terms. What is the pregnancy rate? What is the implantation rate? What is the oocyte-to-baby rate? And thank you for your attention. If you have any questions, I'm open for discussion.
Yes, and thank you for the presentation. And indeed, we have questions already asked, so we will start with the next one, with the first one, sorry. What about 3-day versus 5-day embryos used for frozen embryo transfer? I've heard that 3-day survive better.
I'm not sure how exactly you mean the question. Maybe you mean that the freezing was done on day 3? Because you can freeze embryos in pronuclear stage, it means on day 1. You can freeze embryos on day 3. You can freeze embryos on day 4. You can freeze embryos on day 5, even on day 6. So I
Yes,
don't
I don't
understand the
have.
question exactly.
Yeah, I don't have any follow-up comment for now. So
Maybe we wait for the comment.
yeah.
Mm.
Yes, if we will have it, I will then come back
Mm.
to the question. Now we will take a look at the next one. With success rates, do you have any rates for first cycle, second cycle? So what is the percentage of success from the first round?
The success rate is related to the age group of the patients, and also is related to the number of embryos transferred. So if we have patients with good prognosis in her first cycle and her age is under 35, then the pregnancy rate is around 50%. The same for the second cycle. Speaking about the single embryo transfer, on day 5, so single blastocyst transfer. Answered, I guess.
Yes, and thank you. Thank you for this question and for the question, of course, as well. Next question on the list will be this one. What is the chance of multiple birth and what is the average number of embryos transferred at your clinic?
The average number of embryos transferred at our clinic is 1.4, and the chance of multiple birth for a single embryo transfer is 1.3, as the monogenic twins develop in 1% of single embryo transfers. For double embryo transfer, there is a chance of 20% to get a twin pregnancy. I mean, from 5 pregnant women, we expect a twin pregnancy in one of them.
And thank you for the question and your answer as well. The next question on the list is this one. Age 30, AMH of 3.85 pmol. How many eggs would you expect on average?
For AMH of 3.85 picomole per liter and age 30, I will expect 4 eggs to be retrieved.
Perfect. Thank you for your answer to this question as well. The next one will be this one. How do we choose a good gestational surrogate for a twin live birth?
In our country, for gestational surrogate mothers, is single embryo transfer recommended only. But maybe you come from a country where could or is possible to implant 2 embryos for a surrogate mother. So you should ask those countries where is such practice allowed.
Thank you for the explanation, which is the answer to this question. And we will take a closer look at the next question. I have heard that a good quality egg can heal a poor quality sperm. Is this true?
Yes, we do have scientific data comparing success rates or when a male partner has a very low sperm count and his female partner is of different age group. So we can say the younger the partner, the female, of the male partner with low sperm quality is, the better is the fertilization rate. So we can simplify that the young egg can correct some abnormalities resulting from poor sperm quality, but the egg of a female in advanced age does not have such a capacity to improve DNA damage coming from the sperm.
Yes. And again, thank you for the answer.
Mhm.
Yes, and we have some questions coming up still. So, yes, we have the next one. Do you have any view on a nuclear and spindle transfer?
I believe both methods are experimental. They do not. They are not part of a routine practice, and there have been just few deliveries reported. So I do not have any personal experience, and we don't offer these methods in our clinic.
Perfect, and thank you for this explanation as well. The next question, yes, just appeared, so we will take this one. What is the clinic's chance of success for women at age of 45? I'd like to use own eggs. I had one failed IVF already. My AMH level is considered to be higher than most women my age.
Unfortunately, most women at the age of 45 do have very low AMH level, and we don't recommend any IVF treatment using Aunex anymore. But if your case is different, if your AMH level is really very high and you can get good number of embryos retrieved during the stimulation, then you should also consider genetic testing of embryos to eliminate aneuploidies, abnormal chromosomal count. And if you really succeed so far that after genetic testing of embryos, you have at least one embryo with good chromosomal counts, then you can have very good chance to get pregnant. But I need to answer that most women at the age of 45, despite good AMH level, we don't identify any single embryo to have normal genetic finding. But you might be an exception. I am not familiar with your case.
Thank you for your expertise on this one as well. We have the next one waiting for you. So, in your experience, does a large age gap between egg donor and intended father result in potential problems, example autism?
In general, autism or Asperger syndrome and some psychiatric disorders are probably linked to the advanced paternal age. So males, older males, are statistically more likely to get children with autism or similar syndromes, but we don't know the reason yet. And it is probably not related to the egg donation. There might not be any difference if you do egg donation or own egg treatment. This is a simple age-related risk related to advanced age of the father.
Perfect. Thank you for the question, of course, and your answer as well. Um, yes, the next question, which we have already, will be this one. Age 30 woman asking again. Even though my AMH is low, would you, on average, assume the eggs of are good quality due to my younger age?
Of course, You are only 30 years of age, so you can have excellent quality of eggs. So I will say start the treatment as soon as you can, because your AMH level is low, but you have very good chance to achieve a pregnancy despite a low number of eggs, because you would probably get good quality egg.
Yes, and once again, thank you for sharing with us your question and for the answer. The next question will be this one. What is the cumulative chance of having a baby for a woman at 40 if she has 3 stimulated treatment cycles?
It's a difficult question. In our clinic, for women at the age of 40, we will always recommend genetic testing of embryos. And we hope that in one of those cycles, or maybe in two, we will be able to find a genetically healthy embryo suitable for embryo transfer. If we do so, if we have an embryo with normal count of chromosomes, then we can have 50-60% success rate. But sometimes we don't find any healthy embryo suitable to proceed with embryo transfer. But if you think of 3 cycles, and if we get, let's say, 10 eggs for each cycle, then I will hope that among them will be at least one embryo available.
Great, and thank you for answering even the difficult questions. We will now take the next one. Is 42 years old for an oh, sorry, it was already? Yes, it was. Yeah.
Was not. I don't think so.
Oh, okay. Is 42 years old for an intended father too old?
No, if you mean the autism question above, uh, old father probably is the definition. Who is an old father is related to males who are older as 60 or even 70 years of age. 42 is a young male, and I will not be worried to get high risk of autism compared to general population.
Okay, thank you for this question indeed, and your answer one more time. Yeah. Do you believe that PGTA should be done with every age group, also in case with double donation?
I do believe that in case of double donation is no medical reason to perform PGTA, as the donors must be young, the egg donor and male donor must be young, but it depends on the local practice and legislation of each country. It might different.
Yes, and thank you one more time for the question and the answer. And we have actually the next question coming up. So we will take this precious time and ask it. Is 50 years old for an intended father too old? Out this question of above.
I'm afraid this question should be addressed to a pediatrician or a psychiatrist. This is not a part of IVF treatment. Yeah? So you should contact or seek for statistical data regarding age groups of fathers. I am not the right person to answer this question.
Yes, and thank you for trying anyway, and for the questions which are still coming up. In the meantime, somebody is typing, so I will show you a shout out. Thank you. And as well, one more we have here. That was a very honest answer, which I appreciated, and it was, I believe, about nuclear transfer. And we have the next question, which we can now publish. Are you offering embryo adoption at your clinic? If yes, do you have many embryos to offer?
Yes, we do offer embryo adoption in our clinic. I don't know what you mean, many embryos. We have a substantial number of embryos to choose from and to match you according to your phenotype for embryo adoption.
Thank you for the sharp answer to this question. And the next will be this one. Hello, I have to make an IVF with oocyte donation. I contacted several clinics who asked me to do biologic analysis, but a doctor from Northern Cyprus asked me to perform HSG. Do you think it's important to do this test, which is very painful, and is that this review has adverse effects on my health? The endovaginal ultrasound is quite normal.
I don't foresee any reason why to perform ACG for before egg donation. I don't understand the reason to do the investigation, and I do agree with you that the procedure might be uncomfortable, sometimes a little bit painful, not very painful, but a little bit painful, and I don't need is necessary to be performed.
Thank you for your opinion on this one. And jumping to the next one, how many eggs would you expect to receive from a healthy 20 years old egg donor and a healthy 42 years old intended father? All tests being done.
So 20 years old egg donor, if her AMH level is average and the dose of stimulation drugs is well decided, the stimulation is performed by a well qualified specialist, then I will expect 15 to 20 eggs to be retrieved. And if the sperm of the intended father at the age of 42 is normal, then from those 15 to 20 eggs might be, let's say, 15, 17 fertilized. And that means that to the blastocyst stage, we can expect 5, 6 embryos to develop further to have a good quality of a blastocyst.
And thank you again for the answer. We have a few still on the list. So, what proportion of women in my age, 42, have embryos available for freezing after a stimulated treatment cycle?
At our clinic, we recommend genetic testing of embryos, as I explained earlier. So it depends on the results of the genetic testing. It has sense to store only embryos with normal genetic finding, and sometimes at the age of 42, we don't have any surplus embryos available for longer storage. Sometimes we do, but in average, I'm afraid we have just if good luck, we have just a single embryo with normal genetic finding, and we don't have any surplus embryos left.
Of course, thank you for the explanation. And this will be also the final call for the questions. So if anybody waited until now to ask the question, let's do this now. And we have for now one more to go. And this will be this one. What is the age limit for egg donation in your clinic?
The legal limit for egg donation, if you mean the egg donor, then the donor must be under 35 years of age. If you mean the age of the recipient, of the intended mother, then the legal age limit is 49 years of age.
Yes, great. Thank you for the answer. And in the meantime, the next question came up. So, are you able to provide a live birth rate at your clinic?
Yes, we do. But as I explained during my presentation, we are facing a lot of difficulties because lack of reporting live birth rates, and we are facing some delays because of long time until our patients respond to our questions regarding delivery details. So there is usually a 1 year delay, so I can present now only the data related to live birth related to treatments performed during 2017. As the pregnancy takes 9 months anyway, so and usually no one has time to respond 1 week after delivery. So there is usually 1 year needed since the treatment was done, to have the details available.
Yes, perfect. Thank you for the great question and great answer as well. The next one which appeared is this one. We know that at a certain age, the quality of oocytes decreases. Is there any examination to be done to prove that? I mean, the quality of oocytes.
The, the quality of oocytes is strictly related to the age of the female. So actually, the examination of the quality is the birth rate of the female. AMH testing or ultrasound testing can tell you the quantity, how many eggs could be retrieved, but the quality, there is the criterion number one is the age.
Yes, and thank you. And as I believe we answered all questions, actually, you answered every question which we had today. It will be thinking the time to finish our today meeting. Somebody is typing, but in the meantime, I will as well show you some shout outs which we have. And thank you again for the presentation and for Q&A session. And good job, both of you. Yes, thank you.
Thank you.
Yes, and we can of course continue with that. And yes, we have more. So as somebody was typing, but it's not a question. So as we have answered all the questions, we will be then finishing our today IVF webinars. Thank you all for being with us today and for your time. And as well, Dr. Hana, for your time, for your presentation and your knowledge, which you shared with us. Of course, the rewatch of today's IVF webinar you will find on our website, and you can follow us on our social media, so you will be always up to date. If anything you would like to add, Dr. Hana, please do that now. If you want to do a final comment, you can have a minute or so.
Thank you everyone for your attention. And if you are interested to find more details about the treatment options, we are available. You can find more details regarding the statistical rates on our webpage. Have a nice evening, everyone, and hope to meet you again sometimes in the near future.
Yes, and I encourage you to do that, to search the information, to research IVF Cube website, and of course, their social media as well. And yes, it was a great pleasure to have you here, Dr. Hana, and IVF Cube one more time. Huge thank you. And it will be a wrap. Good night.
Good night.